So thank
Okay.
you very much, Fabio, for your kind introduction and also for the pleasure of working together on the special issue that you're managing for JBI. I will mention it in a few slides. And thank you for the opportunity to present to you my views about what are the current topics and future topics that will become very important for biomedical informatics, and also some of the challenges that we face. And these are insights from two venues. One is from my work as the editor-in-chief of JBI, the Journal of Biomedical Informatics. And the second source is the IHI Rochester report. I will mention it. It is a group of researchers and editors-in-chief of biomedical informatics journals that we also faced this question of what will be the next topics that our research community should focus on. So a little bit about JBI before we start, the Journal of Biomedical Informatics. You can see here myself and Peter Tarzi-Hornock, he's the deputy editor, and all the other people you see here, very diverse group of people, excellent researchers from all over the world. They're the associate editors. And each one has different expertise. Most of them have expertise in machine learning, but also other foci, language models or security or bioinformatics, literature studies, and so on. I'd like to tell you a little bit about the journal, so you can, it will be a setting for this talk. In this journal, we focus on novel methods of biomedical informatics. So we want papers that respond to a need in medicine, but not just papers that take a convenient data set and find some results that they can crunch with existing methods, but they actually have a need that comes from healthcare professionals. They set the research question, and then the researchers try to solve it. And usually there is some gap. The existing methods don't really work that well, and they don't really solve the actual problems that healthcare professionals are facing. And that's where the collaboration between clinicians and biomedical informatics researchers come in, and they develop together and evaluate together new methods, new biomedical informatics methods. And we welcome those papers for our journal. So some areas of biomedical informatics are still out of scope for us. For example, we usually don't consider these papers that are strictly about signal processing or images or medical devices or communication networks, or bioinformatics papers that do not deal with human health and disease. So we want all the potential papers to be novel for a good need, but also to be translational into medical practice. And we want to see some kind of argument or proof that the clinicians were involved in the inception of the study, of the research question, in evaluating that the results could actually be translational. And here I will share the slides with you. There are different editorials that we wrote about if you're considering a machine learning approach, the method should be novel, beyond the state of the art, and the evaluation should be sound and with clinicians. And of course, that you will share lessons learned. And we also have editorials on translational bioinformatics, what we consider there, and about biomedical privacy and security. And this is the homepage of the journal. You can see our impact factor is 4, and you can see some data on the days to decision. And usually it's quite quick. And we have a guide for authors, and we try to explain what is unique to our journal. It is explained at the end. At the beginning, you have all the Elsevier general instructions, but at the end, you will have a section that is specific for our journal. So I encourage you to submit your best papers to JBI. We provide in the guide for authors a submission checklist. And I also want you to encourage to write not just original research papers, but also methodological reviews. They tend to be the papers that are cited very a lot, and it's good for the community to get valuable methodological reviews. It means reviews that are done in a methodological way, and you describe how you screened for papers, where you search, what databases, what kind of search queries, and so on. Okay. I also saw that as an editor, it was quite difficult for me to understand the novelty of the papers. So I asked authors, and I think it really helps them, to write a short statement of significance where they describe the problem. For example, clinical trials conclusions may not generalize to other patients. This is a topic of a paper by Chun-Hua Wang, who is one of our associate editors. What is already known? So what is the state of the art? Like there have been many prior explorations, but they didn't do this or that. And what this paper adds, so what is unique to the method described in this work, and then who would benefit from the knowledge presented in this paper. And this is important for the authors to crystallize this so that every reader, it doesn't only have to be the editor or the reviewer, but every reader can actually understand this quite clearly. It's different from what you usually write in an abstract. It shares some of it, but it is a little bit different. And it is something that you place at the end of your introduction. And it really helps also authors understand whether the paper is appropriate for JBI. So now I come to the talk itself. What are the novel research topics that I think researchers should be addressing? And as I mentioned before, I will have two sources for what I want to share with you. And I will start with the IHI Rochester report. A group of us, you can see here, Carlo Combi, Giulio Facelli, Peter Haddawy, John Holmes, Sabina Koch, Hongfang Liu, Jochen Meyer, myself, Giuseppe Pozzi, and Gregor Stiglic, Perangelo Veltri, and Christopher Yang. We met at Rochester, and it was in 2022. And we tried to think what has changed after COVID, because all things changed. And we identified new opportunities and new emerging topics of research. We were there together and we brainstormed, and then we brought it into a context as a paper that was shared at the Journal of Healthcare Informatics Research. So I will share my contribution to this paper is thinking about first the big movements that shaped our world. And a big movement is the data revolution that most of you are working on now on artificial intelligence or machine learning. And the data revolution is that you have a lot of data and ease of storage and retrieval. And in addition, there's maturing and effective AI methods. And you also have mobile health, and we're collecting through mobile sensors a lot of information about the behavior of people. And we have the Internet of Things, so everything is ubiquitous. The sensing, the getting decision support from devices, everything is unified through this Internet of Things. So this is a relatively new thing that brings a lot of opportunities. But there are also other movements that you all know about, like the trend of evidence-based medicine, that what we practice, not we, but let's say clinicians practice, it should be based on evidence-based studies. I will talk later not only about evidence-based studies, but it shouldn't be that clinicians just practice based on what they happen to see in their medical practice. They need to be aware of what the community has learned from clinical trials, and what is aggregated in meta-reviews and in clinical guidelines, and bringing this data to knowledge pyramid. Another movement was the personalized medicine, and this often uses predictive algorithms to try to personalize the recommendations for interventions for people on their traits and their genome and their behavior. And another movement was that the patient should be a participant of these systems. A patient could learn about the disease, learn how to manage the disease herself or himself, and become more empowered and be a partner in shared decision making with the clinicians, not just stay at the background. And another movement is called the biopsychosocial model of health. So it's not just about treating disease, it's about maintaining and promoting health and well-being. And it's a lot of mental health and a lot of things about being tuned to how your physical health and your mental health come together. And then lastly, there came COVID, and we learned such a huge thing from it. It was a global epidemic, and we all faced the same things. Maybe governments dealt with it a little bit differently, but we learned a lot. The thing we all faced is this isolation that brought a lot of mental health. And, in Italy got, maybe one of the first exposures and huge destruction, and a lot of people who had died because of COVID. And they were not just facing threats to lives, but also what do you do with children? What do you do about their education, their mental well-being, their social well-being? Everyone was impacted for years because of this epidemic. And then we also saw that we can use data, IT, and AI for building the resilience of our society and of individuals. So there was hope, and there was a lot of things that our community can do in the future if we will face other disasters or such epidemics. And things that we utilized were telehealth for physical and mental health, and it's global. Everyone, all the societies developed them. And we, of course, our community developed a lot about new drugs and new immunizations and design methods that use AI for this. We also had contact tracking systems and a lot of questions that were culturally about the privacy versus saving lives. I'm from Israel, so actually our society allowed a lot of sharing of our data. We didn't view it as violating privacy if it was for saving our lives, but in other societies it was viewed differently. So you have to develop a method, but you also have to be aware of the context of implementation of this method. Where are you going to translate it? And what do you need to pay attention to? So it brings different expertise and different collaborations that is necessary from people in fields like computer science or information systems, together with behavioral researchers and legal experts and other types of collaborations like this. And of course, there were data integration and data sharing challenges, because in order to understand, let's say, the impact of drugs and immunization and isolation policies, we had to integrate data that is worldwide, not just from our city, not just from our country. To continue this COVID opportunity challenge that we had, a good thing that also came out of COVID is that the public finally became interested in health. Now when I teach my students information system analysis and design, I can give a lot of examples from the healthcare domain They all know what the virus is. They all know about how to measure. They know how to read graphs better. So this is an opportunity we should leverage. But we also have new threats. And I think the threats are becoming a lot more prominent now in the age of generative models and at the age of social networks, that a lot of misinformation was spread. Another threat was harking, which is an acronym for hypothesizing after the results are known. So you do something and then you change your hypothesis to make it fit well or fit better with the results. And a lot of biases that are introduced in data analysis and also in the machine learning methods and models. Because of that, recently, a group of us, editorial board members or associate editors and myself, we wrote an editorial for JBI about our policy. What do we expect in machine learning papers? The methods need to be novel, but also clinically meaningful, and not just marginally novel. So I encourage you to read this short editorial for further details. And now I want to share with you some of the results that we learned from our brainstorming in this IHI Rochester meeting. We tried to put everything together, and we also worked in 3 different groups. Each group targeted a different phase in the life cycle of data to knowledge. And in addition to thinking about the life cycle, like you start with data collection and you go on to data sharing and so on, we also try to think about 3 levels: the levels of an individual person, the level of the healthcare system, and the level of the research or public health. And in the paper, we try to raise new topics of research or new research questions. And I bring here only some of them to give you an idea. So at the individual level related to data collection, one of the challenges that we have is to harness the power of mass data, of looking for patients like me, to answer questions that an individual is not maybe even aware of, but are important for her. So if we collect data about an individual, the individual shares because she wants to share some of the data. And we find that maybe the individual is not sleeping enough or not exercising enough or doing something that is that could be improved if we share insights about other people with similar characteristics have improved their health by doing this and that, by exercising in this way, by doing maybe yoga. Maybe for other people, it is connecting to their social groups more, and sharing what kind of interventions could be done to improve the sleep, and personalizing these advices. So this is very important for individuals. And what methods can we develop to share, to actually collect this data? How can we collect it effectively and seamlessly? And maybe not only with questionnaires that we don't really like to answer all the time. So how can we learn about it? And another question is at the healthcare system level. Can we develop novel methods for data collection that quickly and precisely collect from citizens the needed prospective data necessary to manage a health crisis? So when COVID started, we needed new data. We needed to know whether people report when they have symptoms of COVID, whether they get immunized, whether they stay isolated or not. And how can we, there were probably at your country as well, we had different apps, and we would get invitations to share our data, and we would get these reminders. And probably individuals don't want to share that much. I mean, they start and then they get weary of it. So how can we actually collect it in a way that we have enough data to reach some kind of conclusions? And then we also need, at the public health level, we need methods to interpret and combine evidence that comes from two sources of data, retrospective and prospective. So we have already data that is available at the electronic health records of different healthcare institutions. So they were collected for a different purpose, not to treat COVID or not to fight something in the future. They were collected to help the individuals and their health. But can we actually leverage this data in electronic health record, this retrospective data, and to integrate it with prospective data collection? So data that we collect from now on using, let's say, forms about the behavior of people and the symptoms that they experience. And we really need new statistical methods that learn about the biases of how to combine and what methods can eliminate or minimize the biases. And also something that we learned in COVID is that some populations are behaving very differently. Like if you look at in Israel, we have the Jewish secular sector, we have the Jewish Orthodox, and we have Arab population. And these are the main populations. They all had different behaviors. Some of them are more tightly connected. They have large families. You can't tell them not to meet. Even their immediate family can be 15 people. In other families, it is 4 people. So obviously, the way that disease spreads in different populations is different. Also, they would respond differently to different incentives. And we need to, when we want them to get immunized, we should motivate them differently. And we should understand and experiment with simulations on what kind of policies would work for different kinds of subpopulations. And also, as we move on and time is advancing, the environment is constantly changing. So the virus is mutating, and people are getting immunized or contracting the disease. So now the chances of virus spreading vary all the time. It's different than at the beginning when the epidemic just started. And this will happen in the future, for different epidemics and for different exposures. All of these we still need to address different subpopulations in a different way. So we need methods that will help us to deal with these challenges. And I hope you will work on these methods. I bring here pointers to 2 papers. One is from my group and the group of Michel Dumontier and Manisha Desai, she's from Stanford, in which we looked at how to combine patient-reported outcome data with electronic health record data. And also about this paper from Gao et al. That is related to COVID specifically. Now I move in the life cycle from data collection to data sharing and data integration. So for COVID, we knew that we had to integrate data on an international level. Thankfully, now there are a lot of standards, and I don't have a slide just on standards, but I hope that you are using in your research and encouraging your healthcare system to rely on standards. And of course, I'm sure that you use standard vocabularies like ICD or SNOMED, but there are also standard data models like the HL7 FIRE, and there are more semantic models like the OMO data model. For example, in Israel, we have a small country, and we only have 7 hospitals that are not private, they are government hospitals. All of the data in these government hospitals have been integrated into a data lake that operates with OMO data model and with SNOMED and ICD codes. And now when clinicians that are also researchers they have a research question, they can go and ask for a Helsinki committee and ethics committee for getting data from several hospitals to allow them to research a certain clinical questions. And I've been advising several projects together with undergraduate students at my department that are in the track of AI, and they have a very good exposure to real world data, to how to work in secure environment, in a research, a remote research room that they can access, and they can integrate the data. Everything is OMOP model, and they can run queries, and they can research this data to address the questions that the researchers have, like what are risk factors for developing bacteria that are resistant to antibiotics. This is one example of a research that I'm advising. So in this IHI Rochester meeting, we talked about different examples. It was before what I'm talking to you about. What I said about this OMOP model was only in the last year in Israel. But here are some examples that have to do with COVID, and some of them not just with COVID. Like, you know, probably that in Europe, there is now ongoing effort to propose regulations for a European health data space. There are cloud digital platforms that provide transparency, controllability, portability, and interoperability of services, which is what we do with the OMOP and the secure research room, which is the Amazon cloud services that we use in Israel. And there is an example of the Gaia X European infrastructure project. I took this from their website. It's actually a quotation. So, oops, sorry for the typo. Data owners retain the sovereignty over their own data. So they do it through a federated system that links many cloud service providers together with users in a transparent environment that can drive the European data community. And this data federation is an approach for data integration that offers a means of querying and analyzing the information from multiple systems. And it looks to you as if everything resides in a single harmonized data store. But you don't really have to consolidate the data into a single store. It resides in different stores, but the access is in the same way. And this is what we also do in Israel with the OMOP model. Another different idea, and I think this idea was maybe before its time. It was published by Amnon Shabo in 2007 in Future Medicine. But I think now the world is ready for this idea. It is an idea of a health record bank. The idea is that you, as a citizen, you want to control your own data, like you want to control your savings, your monetary savings. You want to have experts in the bank that will manage your commodity. The commodity can be data, your commodity can be dollars. And you want recommendations about how to invest. So just like you do for finance, you want to improve your health. And you know that you have health records in different types of systems. You go to the dentist, you go to maybe acupuncture, you go to physiotherapy, you go to a hospital, I hope not. You go to the regular healthcare provider for primary care. And there are multiple institutions. You want to have access by yourself to your own data. Suppose you go abroad for a sabbatical, and you want to present to the doctors there everything that was collected about you, so you can have the best service. if you will have a bank, the bank can do this for you. So you would pay the bank to have a health record for you and to maintain it in a longitudinal and cross-institutional way. So I think we need a lot more work on this, not just to get it to the business side, but what kind of methods could be there? And how can we aid these consultants of the bank so they can recommend to you a level of insurance? And they can go to different decision support systems and consolidate the different recommendations that they can get, and they can bring it to you if you pay their bank. So now 2 questions that I can show you also in individual level and the public health level. In the individual level, we can ask things like, how can the citizens curate their own data to add meaning and context? So we know a lot about our own data, and not everything that we know is recorded in the health medical record. So maybe we can add it. And do we have tools to do it? Do we have tools to visualize and to view what is stored about our data? I remember that I was on sabbatical at Stanford 8 years ago, and I saw a decision support system that was developed for chronic pain. And I was amazed by a question that came on a computer screen to me from this system that was supposed to collect my patient-reported outcomes. And the question said, what kind of treatment do you think will help you with the chronic pain? And I thought, wow, this is such a great question. So I think a lot of these things about getting citizens more involved with thinking about their health and their data and what can help them to improve their health, these are things we need to work on. The last question on this side of the data sharing is on the public health level. For example, how can we take the context and environmental data and add it to the medical record? We know that recently socio-demographic and psychological context is being added. It's very important to have things like your socioeconomic status, your level of health literacy. It's important to do many things to predict compliance, to identify barriers to compliance and to understanding of the recommendations provided by the clinicians to the patients. So we need ways to integrate this. Let me check how I'm doing on time. Okay. So I think the last example that I want to give you in the life cycle is of the learning health system. And this is from Chuck Friedman's paper, that the learning health system can start anywhere, but let's say it starts with data that is being collected, and it can be transformed to knowledge. And from the data to knowledge, you go to performance. You use this knowledge to put it into decision support systems. And after you implement the decision support system, you keep collecting performance data. How, given that you adopted the decision support system, is your performance now improved? And then you compare it and you have another cycle. Now you have more data, so you learn your knowledge. Then you update your decision support and so on. So you have a learning system, and the healthcare system becomes a learning health system. And there are a lot of work we can do there because it's a relatively new idea. So in the individual level, we can develop systems that can increase the resilience and can proactively engage the people who are at risk, at health risk. So when the social surrounding is not available or not functioning, like at COVID or at war or other things, a technical system is at least the second best choice for the individual. At the healthcare system level, we can think about acts, technology, and standards for continuity of care. And it can allow clinicians to use tools that can obtain evidence-based advices based on traditional clinical guidelines, and also predictive models that are trained on data that is collected from similar patients. So you can integrate data that is traditional from clinical trials with data that comes from patients, not from a controlled study. And you want to integrate all of this together. And finally, to the public health, what questions can be answered with citizen-acquired data? And can we inform governments who establish policies based on AI models that were developed from this citizen-acquired data sets? So I want to share with you, this is not from the IHI Rochester report, but it's from a datathon that I helped organize together with our government, the health, how do you call it? The Ministry of Health, and the best winning project. So we had a secure room. It was during COVID, so we each sat at homes, but we remained remote. But we established multidisciplinary teams. We had 80 people participate from academia, from industry, from government, from healthcare. And we posed 3 different kinds of questions. And we asked them to sit for 48 hours, we exposed the schema of the data we would share about citizens, of course, de-identified. And then the 2 projects that won the best places, the government continued to work with the teams on how to integrate what they learned and their machine learning models into their decision-making processes in the government. So there was a decision-making tools for individuals, for school principals, and for city mayors to try out different policies of isolation, of immunization, and then see the impact of this policy on what would be the COVID-related morbidity. And then, citizens living in a certain statistical region and giving their own health behavior, they could view the implications of their behavior. What will happen if we go out of isolation? What will happen to me? What will happen to my environment? What is the prediction? And then principals of schools, they actually had to make a lot of decisions on who to bring back, how many classrooms at the same time will be open. So they could use such a tool. And then the second project was how can we actually change isolation policies for classrooms? So if we know, for example, that a student, only 1 student in class got exposed, and we test 5 more people in the classroom and none of them got the virus, perhaps no one will contract if this student is isolated. So actually the kids could go back to school a lot earlier. And there are a lot more things in this paper, so I urge you to read. These are the different topics we discussed. One of these topics had to do with trust and fairness and equity, which I think is a very important emerging topic. I co-organized together with Xian and Viswaswaran and Yuan Liu a special issue that was recently came out about fairness and inclusion in biomedical informatics research. And we looked at technical and social perspectives. We have a lot of more special issues that came out since COVID, so since the Rochester report. We had a special issue on process mining, on COVID, on natural language processing for secondary use applications, on personalized medicine, on mobile health personalization, on semantics-enabled biomedical literature analytics, fairness and inclusion I just mentioned, and learning from multiple data sources for decision-making, which is Fabio's special issue, together with Francesco, other co-authors and co-organizers. And we have 2 open calls. One is for data generation in healthcare environments, and one is for biomedical multimodal large language models. novel approaches and applications. I'd like to share a little bit, I think I only have maybe 3 minutes left, but about the international collaboration in JBI. I was asked about it in one of the talks that I gave, because the idea is that everything is global, that we should be working more on an international level. So I wanted to share with you what is the state of art now. And this is data up to May 2024. So you can see here that international collaboration is about a quarter of all the papers published in JBI. Institutional collaboration is also about a quarter. Very few people is only like single authorship. And national collaboration seems to be the largest. Here you can see the top number of publications per country and how many of them are national in gray or international. And you can see it's basically like before, it's about a third or a quarter. You can see that Italy is doing very well in the number, given the number of citizens in the country. Here you can see some of the international collaboration visualized. And maybe some other statistics that could be interesting for you is the relationship between medical informatics research and medical fields. So there can be, this is a clustering that was done by the team of Elsevier. And Biomedical Informatics, the Journal of Biomedical Informatics is here. And you can see it is mostly in the cluster that is the medical cluster in red. There's also a biology cluster here, a general data science cluster, and language analysis, natural language, large language models, and so on. So here's where Journal of Biomedical Informatics is. This view shows you all the different topics that JBI papers are about. So they're about all of them. And here you can see that the language processing related papers are those who are most highly cited. So they are more in the yellow. The blue are less cited. So blue are user interaction, biomedicine, language, and the most are language processing. And these are just, some of the topics that are being discussed. And so I think I'm just right about the time, and I'd be happy to take questions. Mm-hmm.